Let's start off the show tonight by welcoming in a good friend of the show, Dr. Gary Payinda. Gary, good evening to you, sir.
Hi, guys. Hi, Pat. Hi, Chewie. How you doing?
Yeah, I'm doing all right. Your T-shirt sings of a sunny, happy person, but there's a few grumpiness in the health industry as of a long term. But what I thought we could maybe do was, there's sort of two stories out at the moment, and the first one is one that we actually covered yesterday, and Chewie pointed out when Simeon Brown basically tried to get the public on side by saying these doctors earn $340,000, meaning they've got enough, they don't need any more. Well, one of the stories that came out today, of course, we asked the question last night as to how much does Simeon earn and what are his qualifications, but now we're finding out that the claims by the Health Minister Simeon Brown that senior doctors were paid on average salary of $343,000. I've had a deluge of emails from our members saying that they earn that much money, there would be no strike action. I'm not sure where he's found the number from he's citing. She said the average salary for a senior doctor was closer to $240, which is still a good chunk of change, but that's not the point. Senior doctors at the top end of the salary scale in New Zealand were being paid less than their counterparts at the bottom end of the New South Wales scale. Dalton said, "We are bleeding people to Australia." And I know there's a couple of things to talk about. Also, the announcements made today around what is building better hospitals, because everything's a radio promotion to these guys. But before we get there, Gary, love to get your thoughts on the strike action. Would like to know from your perspective as well, the reason for the strike, what you're doing, all of the above, sir.
Yeah, that's a lot of issues to talk about, but I think, yeah, if we take them one at a time, I think we can get somewhere. The first one you mentioned, so Simeon loves to say that the average doctor, public medical specialist, is making, what does he say, 343,000 or something like that. And it's interesting how he might have come up with that number, because that obviously doesn't really jive with the income any of us are making. I can't speak for everyone, but I can speak for my colleagues and people I know, and the many people that have commented back in public medicine. I don't want to accuse him of lying or manipulation. I don't know. All I can tell you, if you want a straight answer, and I only want to deal in straight answers and facts, is you can go look up something called the SECA, the SECA. I don't even know what it stands for, but it's the salary list that shows you exactly how much medical specialists in this country get that are working in the public system, salaried medical specialists. So if you look, it'll have 15 steps, 15 levels. And when you come out of training, you'd be on level 1 or step 1. And 15 years later, as you've gotten seniority and experience and assume a senior role in your department, you'd probably be on step 15. And then if you stay longer than that, your salary doesn't keep going up. So step 1 is $185,380. So a medical specialist, that's how much they make at step 1. By step 15, the maximum you can make is $267,980. So sorry, $267,980. So I assume he gets his 340 by adding up an imaginary concoction of annual leave and continuing medical education and sabbatical pay and maybe other benefits, medical books that we can buy, medical conferences we can go to with an allotment of continuing medical education money. That's what I assume. He also really talks a lot. He loves saying this, that doctors get sabbaticals every 6 years. In our SECA contract, our medical contract for the public doctors, we do have the ability to take 3-month sabbatical every 6 years. And the point of that would be for example, you could do a course in infectious diseases somewhere.
Yeah.
My wife went to South Sudan to volunteer with Médecins Sans Frontières, right? Doctors Without Borders. So it's a chance to refresh your hope and life and interest in society and helping and do something different, and then come back to your medical practice in the public refreshed and engaged and maybe more educated, and maybe use that time to get up to speed on a aspect of medicine. So Simeon wants to say that these essentially lazy doctors are getting all this time off. And so again, 12 weeks every 6 years. I've been working in Northland for 17 years now. So by that logic, if you do the math, in another year, I should be able to have my third 3-month sabbatical. I've taken one in 17 years. The vast majority of medical specialists in the public system have not taken a sabbatical.
Right.
To go away for that long when your department is profoundly understaffed is not realistic. I could by my contract, by the law, I could insist on it, but most of us don't want to screw our departments and our colleagues. And because when we leave for even just for annual leave, there isn't like excess staff to absorb the demand. Someone's still got to run the clinics and see the patients and do the procedures. And so Simeon has no health experience whatsoever, right? He has no idea what it's like to be a healthcare worker or a doctor, nurse, any of that. There's no respect for him within the group of doctors and allied health and nurses. Okay, don't exaggerate. There's not none. He probably has maybe an aficionado here or there, but the vast majority of doctors and nurses and allied health staff that I have ever talked to, and I talk to a lot of people at the hospital and across many hospitals across New Zealand for my various roles, we do not have a significant amount of respect for what he says, what his actions are, what he does, or how he runs things. He may think that we're taking sabbaticals left and right, and it just shows you how utterly clueless he is. He has no idea. The reality is that we can't take them because doing so, even though we're contractually able to, doing so would screw our departments and ultimately hurt patients. And we've shut down our practices for too long to do that. So he lives in a dream world. And the things he says, he can get away with saying with absolute impunity because no one is there when he says this bullshit. And yeah, I, for one, am tired of it. And I'm gonna directly confront his comments and his lies at every juncture. And because they come out so frequently, that may end up being every day. I don't mind it becoming a side mission for me because someone needs to speak out against this. I mean, people are. ASMS, Sarah Dalton, and all the leaders at ASMS have been. But the pace of the BS that comes out of this current government towards healthcare workers, whether you've got the future deputy minister calling us Muppets that should be put back in our box, right? That's how he referred to public health physicians who have dedicated their lives to trying to reduce outbreaks and ensure clean water and healthy communities and all of that stuff. We've talked about it before on the show. But yeah, suffice it to say, what we get paid is in the public. You could Google it right now, and in about 10 seconds, you can see. And the really interesting thing to point out, and I don't want to be in this position of like trying to defend highly paid people when the real issue is understaffing and patients not getting care. But because he's got to put these lies out, someone has to say something. So I want to point out to you that Simeon Brown, the health minister, his only health experience is founding an anti-abortion group at the University of Auckland. That's the closest he's gotten to healthcare, and being the spokesman for a group that is anti-family planning. I do not understand how that is even a thing, but the man was the spokesman of an anti-family planning group. That's the closest he's got to a healthcare experience, basically trying to stand in the way and obstruct women's healthcare. So this man has become health minister, and he's criticizing doctors for their pay. Simeon Brown has a degree in finance, business, something like that. Presumably a 3-year degree. I wouldn't expect it to be more, maybe 4, probably 3. So he's in uni for 3 years, works as a bank teller or a bank employee for a few years, and then becomes a career politician. That man is making $327,000 a year as a cabinet minister. You know, he's the minister for health, making $327,000. That is almost twice as much as a medical specialist doctor is going to make in their first year out of training. The difference, though, is that that doctor will be providing an essential service to society in a way that Simeon could only dream of. The difference is that Simeon, with his 3 years of post-high school education, came out at a young age. And the difference is that that medical specialist worked for 13 years in study and in medical training before they could even call themselves a specialist. That's 13 years after graduating year 13 high school. So these people have been in study and in hard work, working their asses off in many cases, most cases, I would say, really trying to do the best for their patients and getting out of training at age 32. I don't know how old you guys are, but if you're a specialist doctor, on average, you are finishing your training at age 32. And think about this. You will be leaving that training, becoming a specialist, earning half of what Simeon Brown earns, and being told that you make too much as a public servant. Okay? You may be a pediatric surgeon. You might be a radiologist. You might be an emergency doctor. And you are being told that essentially to stay in your place and to accept a contract for payment that is less than the cost of inflation. Inflation right now is 2.2%. In a couple of years ago, it was much higher, 5, 6, 7%. Inflation in healthcare even worse. But let's even go with the best number, 2.2. As our union has said, the government, Simeon, etc., Luxon, all of them, have proposed a total package of remuneration, a pay package with benefits and all the rest, that is around 1 to 1.5%. Okay, so less than the cost, less than the price of inflation. And this guy is telling us that we should accept the negotiation, that we're too highly paid. This hypocrisy, I don't know, is anyone in media other than you guys calling this out? This is insulting. I was on Ruth Hill for like a 5-second little blurb. So, I mean, there are some voices that are looking into this, and I respect them and value them and say thank you to Ruth Hill and you guys and everyone else that's been on the side of just openness. But, I mean, look at this travesty. The people in the union will tell you that a doctor on the highest step, so the senior doctor in their department, on step 15, who's been there for ages, been within the public system, committed to public patients and the service of the public, they're making less at their top step than a brand new graduate going into the medical specialty system in Australia. So a first year grad. So if you wonder why we're losing good people to Australia, and you don't have to look too far to realize it. With a 3-hour flight, we could be making 40% more, literally the same day if we wanted. It's easy to get registration. Most of us could do it no problem, but we don't, because we love New Zealand. We love working in New Zealand. We love our patients. And we find what we do highly rewarding and valuable. That's why we stay in public. And Simeon,
I take the silence. I take the
nothing
silence
but contempt. Has nothing but contempt for it, is what I wanted to say.
Yeah, and that's a very almost polite professional way to say it. I understand. I bet it feels different to be thinking what you're thinking, but saying what you're saying because you're sort of part of this. Do you want to explain to us? So he's trying to sell the idea that these doctors in New Zealand are paid too much. It reminded me as well. Remember, Luxon also came out saying nurses were earning 120K. So they have form in this. That he's coming out trying to say doctors are earning too much, and if you go on strike, you're going to hurt the patients. Do you just want to give us a couple of minutes to synopsize on why the senior doctors are actually going on strike from a senior doctor's point of view?
Yeah, I mean, to insinuate that we are the ones hurting patients. Look, the reason I strike is not about the money. The money is the only lever I have, other than Twitter, other than chatting with you guys. It's the only lever I have to affect change within the system. Our entreaties, our pleas have fallen on deaf ears. We've been, the modern term is gaslighted, but basically just bullshitted to, saying that things are better than they are. We tell them there's a hiring freeze. Could you stop the hiring freeze? We have really critical situations where patients are dying and there's no doctor at these doctorless hospitals to manage the resuscitation. This is real things. And in the case I'm thinking of, the nurses went on like a 1 day or half day action, like a strike, something like that, to say that they felt unsafe. Why? Because it was unsafe. And the strike is like the one thing we can do that might affect government, might affect these dead in the head politicians who have no souls, who are ideological and essentially have no experience in health and no humanity. So what can we do but strike? For me, and other people may feel differently. Other people may feel the money's a really huge issue and that's the focus. But the people I talk to, my colleagues, the problem is the understaffing. The problem is that I have to go, and my colleagues and many emergency doctors around the country and other doctors go into a room and the first words out of our mouth are, "We are sorry." You introduce yourself and you say, "I'm sorry that it's taken me 4.5 hours to see you. It wasn't my intention. We're very busy." Now, we don't tell them the full, honest truth, which is we are so badly staffed. We do not have sonographers to do the ultrasounds. There are not enough people doing CTs. We do not have the MRI machine going as often as it needs to because we don't have the staffing for it. We've got surgeons that David Bailey of obstetrics and gynecology has said to you that he has women who have been waiting over a year for surgery. They've got pelvic pain, chronic bleeding, and they're made to wait. And he went to them and said he and his colleagues can do surgeries on the weekends, on Saturday catch-up lists. He did say, of course, you'd have to pay us for that. I mean, that's pretty legit to think you wouldn't have to work, 6 days a week and the sixth one for free. He said, pay us, and please hire a theater nurse to run the theater, to help out in the operating room. And they said no, they wouldn't do that, but they would give $50 million for patients to be seen in private. 10,579 private cases, surgeries, procedures to be done in private, sucking the surgeons away from public into private, sucking the anesthetists with them, sucking all that resource that should have gone to paying for the theater nurse, the new CT scanner to replace our decrepit one, fixing up our infrastructure. Instead, what you will have is a private sector that gets more and more enriched at the expense of the public. This is the solution of these intellectually bankrupt leaders. Privatization is their answer, not rebuilding a public health service that takes care of people. So I don't know what to tell you. I guess does that answer your question?
And then some. I think it's also a bit of a good lead into the second kind of conversation, which is coming up today, because you're talking about public money going to the private sector. We've had an announcement today that we're going to get some infrastructure built, but there is also, always that caveat with the Tories that, the private sector is going to help us be able to do this. If we watch this 3-minute clip, then maybe you can comment on that and get your thoughts around that, if that's okay. So this is one news tonight.
Thinking. That's the promise from the Health Minister as he unveils a plan for future infrastructure development. The issue, our ageing healthcare real estate. There are 1,200 buildings across 8.
And as you always say, Chewie, they identify the problem. It's their solutions.
Oh, so good at it.
That seem wanting.
56 campuses with the average age 47 years. And that means a need for major repair work to avoid disrupting services. Some buildings have poor earthquake ratings and are outdated for modern care work. The government is calling the fix building hospitals better. The plan, set over 10 years, is to move away from mega builds to more financially manageable staged projects that develop hospital sites over time. The hope is that patients will get the benefits sooner and there's greater certainty around delivery and costs. It includes new acute services buildings, inpatient units, and expanded emergency departments and wards. It'll take $20 billion. So how to pay for it? Corazon Miller has more.
The vital signs of our hospitals and health clinics are in decline, but Simeon Brown says he has a plan for resuscitation.
It outlines what needs to be done and how we would do it, ensuring New Zealanders have access to modern, safe and reliable health infrastructure.
It's critical for us. It's signalling an uplift in investment to address the long-standing deficit in infrastructure.
The money to address the deficit will be set aside across several budgets.
New Zealand has got into a deficit with health infrastructure over a period of many, many years. We won't be able to fix it overnight.
Making it clear for the $20 billion makeover to happen as planned, significant private investment still required.
We're open to all types of funding and financing opportunities to deliver the health infrastructure that we need.
By having the pipeline, we're starting to see what is needed over a period of time and will give investors and local construction companies opportunity to build up capability.
It's hoped the shift to smaller builds will also help see projects delivered at greater speed and within budgets. Among those that have already been given the green light, a new hospital in Auckland's rapidly growing south. And after some delays, the construction of Dunedin's new hospital will soon be underway.
Works will recommence on the new Dunedin hospital site the middle of this year.
It's all talk from the government at this point. I think we want to see some action. So far, all they've done is slow down action to rebuild our hospitals.
Other projects being eyed up include the revamp of emergency departments, seismic strengthening, and the purchasing of land for future builds. But there are questions over how the government will deliver what's needed without a similar investment in the workforce.
We need more doctors. You cannot just build a facility and hope that that will take care of the healthcare for a community. This plan says it wants to upgrade IT systems. It's hard to take that seriously, given they're getting rid of IT specialists at hospitals all over New Zealand.
While a plan is one thing, the government now needs to make its vision of better health services a reality.
So there you go. Building better hospitals on Auckland's 918 More FM. I assume it's a radio promotion. And concerns by many around, if we have these buildings, how do we staff it? And what does private investment mean in this public system? Gary.
Talk is cheap, words are meaningless, and all we should care about are actions and real things that are delivered to patients. So they can say whatever they want, but the words are good. So the words they are mouthing are good. So they're going to rebuild, refurbish, additional. It all sounds wonderful, like fantastic, good on them, excellent. Put the money towards it and make it happen. The reason I have little faith in it happening in a productive way is because I know that they've pushed a couple different things that are getting us further away from equitable, good, effective public health care, cost-efficient public health care. One simple example is they're very good at making targets, right? We're going to have a target for ED, a target for a first specialist appointment. But what you see is that they don't make a target for filling the understaffed nursing roles. They don't have a target. They don't even want to talk about the actual number. The number is probably somewhere in the vicinity of 3,000 nurses and approximately 2,000 doctors that we right now at this moment are understaffed by. That does not count the almost double than that number that will be retiring in the next 10 years. It doesn't talk about meeting unmet need due to poverty and other things in the community and an aging population. Literally right now, today, we're approximately 2,000 doctors down, approximately 3,000 nurses down. That should be the target. That should be the number that they get us closer to. But of course, that's not a target. They will put a target on something like first specialist appointments, which sound wonderful. Like I get to see my cancer specialist in a timely fashion. Excellent target. But what the oncologists are telling me is that the slots for the patients to be seen on their first specialist appointment come from eliminating second and third and subsequent follow-up appointments for people, delaying them. So we've got oncologists that are pulling their hair out because they do get the patients prioritized into a first visit, but they're not able to then see what's happened to them after they've started the chemo in a timely fashion. So they want to see them within 3 months. It is just not happening. And of course, there's no target associated with that. And so months and months and months are going by, and these oncologists don't know if their patients are responding to chemotherapy or not. And it's not just oncology. I just use that as one example. We have grave situations happening in ophthalmology with patients going blind due to an inability to get them back in, due to not having enough staff to get their injections or Avastin injections for things like macular degeneration. We've got Middlemore Hospital, which has now had deaths in the waiting room, plural, with an unbelievable amount of unmet need there. The need for staff is overwhelming. They are pushing 450 patients in a 24-hour period. This winter, they will probably crack 500. And what they need is staff, and they need staff now. And what they're not getting is staff. We know that there's a nationwide hiring freeze but the government will. This is why words don't matter. The things they say don't matter, because we tell them there's a hiring freeze. Managers are telling me they're going in with dozens of positions that they need to get filled, and they're hearing nothing back, or they're being told 2 positions out of 45. That's how many you can hire. So there's just a disconnect between actions and words. Malcolm Mulholland, I just spoke at a road show he was doing around the country. It came to my town a few days ago, and Patient Voice Aotearoa, I think is the name of his organization. He's a good guy that, his wife died of metastatic cancer. She fought hard to try to get chemotherapy drugs to be funded. And since then, he has fought on her behalf and on behalf of all the other patients to get increased funding to Pharmac. And he's had some success with that, some real good success. Now he's turned his vision towards like the clear and present danger of understaffing in the country, poor infrastructure. And that's who you heard talking. We need more doctors. It's not rocket science how you get them. If you're hemorrhaging them to Australia, if you're not paying them enough, but most especially if you are making them do the work of 1.4 or 1.6 doctors, which is the standard really now. Throughout the country, we've got 10 to 45% vacancies in medical departments for doctors. Can you imagine working in a medical department that's lacking about 1/3 of its doctors? You are busting your butt every day to barely keep your head above water, and even then at times not. And so they can announce all the targets they want, all the plans. What was the name they gave to this? Build back better, build better stuff.
Building hospitals better or some stupid.
Yeah, okay. Building hospitals better. It's a great idea. Like, who wouldn't support that? But now fix the staffing problem, show you're putting money into it. Like at my hospital, they talk a lot about the rebuild, but they've broken it up into multiple stages. And the stage that actually gets us, the 158 bed patient tower, like where the medical and surgical wards will be, where the patients will sleep, that hasn't been received any money yet. So they say it'll be operational by 2032, but they've not put their money where their mouth is. And so do I believe it'll get built and on time? Certainly not. But surprise me, Simeon, knock my socks off. Show that you've allocated funding towards it and that it's started. And of course, then I'll believe you. At this point, we should believe nothing they say, but we should believe everything they do. So if they achieve good things, we should respect that and give them due credit for it. So those are my thoughts on that. I liked how that person pointed out IT. The government has said they value IT. They understand that our system is broken and fragmented across 23 DHBs, that I can't look up labs or CT scans or cancer history, medication histories on any patients outside my region. It's absurd. There's a duplication of studies that has to happen, a waste of money. It's unsafe. Certainly there's patient harm. And so the government will say, yeah, this is a clear and present danger. And what do? The plan that was in place for several years that work had been begun on to modernize and centralize information technology, the computer system that we use in healthcare, was canceled by them. They canceled it, took the money for other things. What other things? $216 million for Philip Morris Tobacco Company. $2.9 billion for property investors to help make their mortgages more affordable than yours. And you just simply someone has to confront him. Please, can you guys get me some time with him? I want to talk to him.
Would love to. We'll do our best. Would love to, Gary. They don't want to come and even talk to us, and we're only like 1/10 as scary as you are, my friend.
So I want to know why they don't reverse the property investor scheme that sees taxpayer money go to making mortgages more affordable for landlords. As I've always said, if you want to exempt the poor little landlord that has only one rental property, more than happy, we can negotiate that. But for a mega landlord that has 40 or 300 units, I do not want our tax money subsidizing that person. I want it going to healthcare. I want it paying for patients' prescriptions, which we know is cost effective. The literature shows it. They got rid of the subsidy for prescription fees, so patients are going to not get their meds and come in sicker. So they talk a good game, but the reality is, at every juncture, IT, we needed it, they canceled it. GPs, that's just insulting. GPs had literally years of data from Sapere and all these fancy consulting groups, paid for by the government, paid for by the GP practices, all aligning on the fact that they need better reimbursement than they've been getting. They needed something like 14% minimum raise in capitation to be able to take care of general practice primary care patients. This government said, we love you GPs, you're the backbone of our healthcare system. We're going to give, but we're only going to give you 4%, but you can charge the patients 7.76% more. They said, but our patients can't afford that. I said, well, that's their problem. That's your problem. We can give you 4%, even though that's less. At the time that came out, that was less than the cost of inflation. So don't tell me what Simeon Brown or Christopher Luxon or any of the coalition, Seymour, are saying. I do not care. I only care in demonstrable facts. Show me what they're doing, because I can show you a list of things they have done which have been more expensive for this country, inefficient use of taxes, will cost us more in the long run. And so you have to say, are they stupid or are they negligent? Which one? And the reality is there's one underlying principle that I want to get to, and I've made this point before, but the idea is, if you see a bunch of things that just seem insane, why would you get rid of these prescription copay, bring back the copay? Why would you do all of these things I've been talking about? Ask yourself one question: does it benefit private corporations? And every single thing I've seen them do has. They got rid of the world's best anti-smoking laws. New Zealand had the chance to historically reduce smoking rates and save literally thousands of lives a year and reduce harm. Emphysema, lung cancer, all kinds of cancers, heart disease. It would have been massive. That law was repealed by them. Okay, this government, under urgency, as quick as they could, got rid of the anti-smoking laws. They're called smoke-free laws. You should look them up. They're amazing. Yeah. They canceled those laws, and shortly thereafter told Philip Morris Tobacco Company that they could have $216 million to reduce excise taxes by half so that they could sell more heated tobacco products. So I'm going to just say, sorry to bleep this, but they can go to hell. This government can go to hell for what they are doing. If you are on the side of big tobacco corporations and you are taking taxpayer money to help tobacco companies, you do not deserve a role in government. You do not deserve to be looking out for the well-being of the people if the actions you do actually harm people, patients, my patients.
Gary, I don't think anyone really knows how to respond to what you're saying.
You don't have to respond, and it shouldn't be up to you, and it shouldn't be up to my poor patients asking what they can do. People writing into me saying, can we go bang pots at Shane Retty's office? What can we march? yeah, you can do all those things. It's wonderful. I love the support. It's not up to you to answer or to speak to it. It is up to the people making these decisions, the leaders, to be here and to front up and to answer these things. And I challenge any of them to.
That was righteous. You are justifiably angry, and all of your patients must be so lucky to have you in their corner. You're 100% right on all of this. You've linked.
Look, I'm sure I have my bad sides. I'm sure I've got people that dislike working with me. I'm sure I've made mistakes with patients and been short with them at times. Like, I'm sure, you know, no one's a saint and nothing's perfect. But the point is, what we're facing is really bad for the country. It's bad for society, and it's bad for patients, and we need to not tolerate it anymore. I'm sorry to have interrupted you, Chewie. Sorry. Go ahead. I'll shut up now. No,
I put it in the chat of like, stand back, everybody, let Dr. Gary cook, and you cooked. Wow.
But is the thing that I don't want to be like, hey, let's all be, you know, white knights now and shining armors. But Gary, we all are there with you, and I know, like we've said before, marching is maybe not the answer. But what is? What can we do? I mean, we can get your voice
answer. It's an answer, but it's not the answer. It's not the thing that will move the levers. There are two things that will move levers and change the trajectory that we're on in terms of essential public services and the social well-being of people in New Zealand in the face of changes that will benefit privatization, corporatization. There are only two levers I see. And yeah, you can rally, and you should. It builds community. It's good. But if you don't affect Simeon Brown's and Christopher Luxon and David Seymour's ability to get money from corporations and their ability to get reelected, you know, via media, you will likely lose. You will likely achieve nothing. Because if they have vast corporate donations and wealth, and they have corporate media support, the chance that you or me or my patients or their whānau will make a significant difference is vanishingly small. I'm not going to say useless. You know, we need people to show up, but we've got to target our actions to where it counts. So I think target your actions to the politicians. Make it so that they cannot ignore the situation, and bring the fight to them. Don't suffer silently. I mean, my patients in Northland are amazing. They will wait 4.5 hours in real pain, you know, with fractures or abdominal emergencies or just really painful, you know, whatever, wounds, infections, and they will still say thank you and be very appreciative, almost to a person. With very rare exceptions. They're just amazingly tolerant. I was advised by a pretty smart guy that we can make it so that politicians can't ignore the public too easily. When you write a letter to them, try to bunch it up with 2 friends. If they get 1 letter from 1 person, it's meaningless. If they get 3 or more letters clustered in a week, they begin to understand there's some meat behind it. There's some motivation there. It may be a real issue in their mind. That's still assuming that there's actually not malign intent on their part to privatize and to basically help corporations make money. And yeah, so that's relying on them to be good. The other thing you can do is bring the protest to their face, bring it to their offices. The best suggestion I've heard lately is a pots and pans protest, where you show up at their office during their office hours and you make your dismay known. if you're on those waiting lists, if you're one of those people that can't get care, or their family or loved ones, show up, be loud, and bring media with you. You do not do this silently. Do not let them dismiss you. Bring media with you. And if that needs to be you in your own phone, filming it and live streaming it, so be it. But if you can get journalists there, wonderful. There are still some of them that are interested in pursuing public interest stories, even within the very corporate realm that they live in, that basically broadcasts business owners and CEOs' opinions on healthcare above those of people who've devoted their entire lives to studying healthcare management and the provision of healthcare. That's number 2. Number 3, build community. That might be, with people in your area. There are good doctors and others, nurses and allied healthcare workers around the country that are speaking up. You saw the doctors in Nelson come out strongly, showing us the truth of how how bad their system is. And it didn't get this way accidentally. This is intentional underfunding. It can be fixed. Tomorrow, they could reverse the property investor tax cuts and funnel that money. Do you have any idea how much $2.9 billion is? It's enough to completely fix every doctor shortage in the country and every nurse shortage, and provide free public dental care for every New Zealander. It is enough to do that. That is the quantity of money, the immense pile of gold that has been given to property investors from your tax money. And of course, you won't hear the taxpayers union talk about this at all, ever, not once, because obviously they're not really a taxpayers union and they're not really in support of taxpayers, nor are they a union. They're a political operative that won't talk about this, but someone's got to. And so, don't let them say the money's not there. It is there. It could be redistributed today to the groups that need it. But it's a choice. So those are some options. You've got to affect their ability to get reelected, and that's about bad publicity for them, because Simeon does these little speeches and then disappears, and every one of those is a little burst of news that he's getting free. We can't let it happen. People need to be showing up at his speaking engagements and speaking truth to power. This is the time where people can confront him with actual facts and reality. So it's got to affect their ability to get reelected and their ability to get corporate donations, which they are really good at getting for obvious reasons. And you've got to reduce the amount of money that they're able to get from corporates in the pursuit of a stream of untruths, half-truths, mistruths, and lies. So we need to do more of this. More of what you're doing, I think, will make a difference.
Well, Gary, if we can help with hindering them getting re-elected, that's kind of our set. That's our expert set. We can get involved in that. Happy to for the next, what is it? Not even 18 months anymore, Chewie.
Yeah. One of the things you said there, Gary, is clusters of letters and emails arriving all at once sends a hell of a message. There are 800 people watching us right now. Wow. There are 800 people that are deathly concerned about the state of our health system and the slash and burn corporate raider vandalism that this government is raining down on it, and it's going to affect all of us. It's not going to care whether you voted for National or ACT. It's going to come to your door as well. So if you can hear me, and more to the point, if you can hear Gary, then you need to put these thoughts in an email tonight, tomorrow, end of the week. That's our homework assignment this week, is to let Simeon Brown know that this is not unnoticed and will not fly.
And you know what? If you're going to do that, blind carbon copy bighearingnews@gmail.com. And we'd like to see if people are doing it. So BCC, bighearingnews@gmail.com when you send your emails off. And if you ever get confused with their names, it's real easy. We use it all the time. It's firstname.surname@parliament.govt.nz. That's how you get them. Blind carbon copy us, and we'll share some of them. Happy to share some of them on the show.
And one thing I'll put out there is I try to talk about facts and back this stuff up with links, but I can't put a bibliography or a reference section on this conversation today. But I have written about all of this stuff before on Substack. And Substack is it's like Twitter, but not for rabid neo-Nazis. It's kind of like a thinking person's site where you can read longer journalism and take some more time and learn things a bit more in depth and interact. And I have learned a lot from healthcare workers and patients around the country. And I try to put some of that on the Dr. Gary Payinda .substack.com. I'm not even sure if that's what it is, but if you just put in my name and Substack, you'll be able to read stuff. And I try to post all of this stuff on there so that it lives on and that people can reference it, because I'm not expecting that people can memorize all this stuff. But at least it's a repository for people to go to if they need to. And I talk about not just healthcare, but there's more to this than just that. Privatization goes deeper than just healthcare.
If people are watching on Facebook or YouTube in particular, your Substack is in the show notes as well. So people can just go to the show notes and find the link there as well. Hey, Gary, thank you so much for being with us. I don't think any of us, including you, knew that we'd be chatting for an hour, but we are more than happy to, especially when on other outlets, they give you literal seconds. This is what we want to be able to do. We want to be able to give the people who know the space they need to tell the story. And I think most in the chat, me and Chewie would agree, that has been you in spades tonight, sir.
I'm sorry for taking up an hour of your show's time.
No, don't be sorry. I'm saying it's a good thing, Gary. It's actually what we're here for. We want to keep talking until the conversation's finished for this night, but I'm sure we will be talking to you again as this conversation continues in other areas.
Hopefully. All right. Thank you, Pat. Thank you, Chewie.
All right, Gary. All the best.
Keep up the good work.